Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lundbeck and Otsuka.
This program is presented by Medscape Education Global.
Hello, I'm Ali Reza Atri, Chief Medical Officer for Banner Research, Banner Alzheimer's Institutes and Research Institutes, including Banner Sun Health Research Institute in Sun City, Arizona. I also serve on the faculty of Brigham Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to this program titled A Roadmap to Relief, Managing Agitation and Dementia Associated with Alzheimer's Disease. This is a program that includes a series of short lectures by experts in this area. We will start with someone with firsthand experience with caring for a loved one with AD dementia and agitation. Then we'll further discuss the burden of this aspect of Alzheimer's disease with Professor Zainur Ismail, Professor of Psychiatry, Neurology, Epidemiology, and Pathology at the University of Calgary in Canada. Next, I will cover detection and diagnosis of agitation in patients with AD dementia, followed by our mainstay, which is non-pharmacological approaches that we can use and must use as the foundation to reduce agitation. We will then move on to pharmacological approaches and strategies with Professor Krista Lanto. He's Professor of Psychiatry and Pharmacology and the head of Neuropsychopharmacology Research at Sunnybrook Health Sciences Center in Toronto, Canada. And she'll discuss mostly approaches that are used in clinical practice, and many of them are off-label therapies, because until recently, we really haven't had labels and approved medications. So that's recently changed, and you'll hear about this more from Professor George Grossberg, the inaugural Henry and Amelia Nasrallah Endowed Professor at St. Louis University School of Medicine in Missouri, USA. And he'll cover the latest data, including the most recently approved therapy for agitation associated with AD dementia. So why is this topic so important? As you'll hear, agitation is highly prevalent among persons with AD dementia, and it really takes an enormous cost on patients and caregivers. So it's something that really requires our attention, but oftentimes we've not had the language to speak about it or some of the approaches to mitigate it. However, recently, after more than a decade of work, we do have a common language. The International Psychogeriatric Association has a consensus definition of agitation, and it has a number of things that one has to think about. First, the patient has to meet the criteria for cognitive impairment of dementia syndrome, such as Alzheimer's disease. And then next, they really have to have behaviors that are exhibited, at least one that's associated with emotional distress, and that's persistent and frequent enough for at least 2 weeks. So it's not just something just happens, overnight. So one behavior, at least 2 weeks, and this is a change from their usual behavior. And it can be categorized in different ways, but one of the ways you can categorize it, and the IPA did, was thinking about motor activity that's excessive, verbal aggression, or physical aggression. And we'll delve into those things more. And of course, these behaviors have to be severe enough to cause some sort of a disability beyond what is going on with the dementia. So it has to be severe enough to impact interpersonal relationships, for example, other aspects of social functioning, or really them supporting their ADLs or being able to receive care. So that's another component. And finally, this cannot be attributable to any other cause. So now that we have our definition, we can actually use it and use examples of it to discuss and educate patients and care partners early, and for it to be on our own radar. So in the next segment, I'd like for you to hear about what agitation means firsthand for a caregiver or partner.
Hi, everyone. I am Bonnie Berman, and I'm so glad to be with you here today. What I want to do in the next few minutes is share with you my experience as a care partner for my mom, who lived with Alzheimer's in the early 2000s. I also want to share with you what I wish I had known then, and hopefully that will help you now. As her disease progressed and as her agitation increased, I think the agitation became the most important issue for us as a family. It dominated our interactions and really our lives. And my most important takeaway message, is there is so much that we as care partners can do to ease the pain that resulted in agitation. And I'm going to use my stories as kind of an example of that. My mom's agitation started when she was living independently with dementia, and I believe it was the agitation more than anything else that caused her to spend the next 5 years of her life in a nursing home. It's funny, we so often as care partners think of memory loss as the most important issue, but the truth is, in our case at least, it was her agitation and the personality changes that accompanied that really were the biggest issues for us. My mom's agitation was expressed in a number of ways, none of which were violent, none of which were aggressive. For her, it was restlessness, confusion, repetitive behaviors, and most importantly, and I don't think this is a real technical term, it was what I call agitation-induced sadness, which caused her to retreat into herself. So let me explain. What I know now is that a lot of her agitation was her trying to express something. And in most cases, it was either physical or psychological or emotional pain. And it was also, her agitation was a result of our inability to read the signals and to understand the triggers. So here's an example of both what happened and how the agitation started and how it affected our relationship. One day I walked into my mother's room, and instead of pictures of 5 grandchildren, there were pictures of 6 grandchildren. And I am shocked at my own reaction to that, because all I could think of was like, don't we matter? I mean, it could be any child up there. And I was really hurt. But what really motivated my behavior after that was the sense of the stigma. I did not want anyone to know that my mother was out there stealing people's pictures. And then there was also the part where I felt so bad that, like, were we no better than this person? Did she love us? No. Didn't she love us more than this person that she had never recognized or never seen before? And what my mom would do is she would count the pictures. Here's 1 grandchild, 2, 3, 4, 5, and then she'd get to 6, which would be my trigger. And so I erred at that point on so many different levels. First, again, because of the stigma, I didn't want anyone to know that she had done that. And so what I did was I went around to other rooms and I found somebody who had the same kind of frames, and I returned the picture. And because I did that, my mother would count her grandchildren, and the 6th one was missing. And oh my gosh, she was so incredibly agitated. And I made it completely worse by saying, that was not your grandchild, Mom. These are your grandchildren. Did it really matter? What I know now is to just go with it and not try to correct and not try to help her understand that she was wrong. Because the truth of the matter is, people with dementia don't remember exactly what happened, but they're going to remember how you made them feel. And I made her feel absolutely terrible. And as a result of that incident, I actually was, it was just too much for me. And I was diagnosed with mild depression. In addition to the mild depression, the impact of her agitation, especially the confusion and the pacing, was really substantial. The worst time was when the nursing home staff asked me to leave because she was so agitated when she saw me. I had just driven 400 miles to see her, as I did every 3 weeks. And what happened is I said, "Hi, Mom, it's Bonnie." And it was so clear to her that I was not Bonnie. She was so agitated by that. And instead of just going with it and explaining and just having fun with whoever I was to her that day, I kept at it. No, 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 I am Bonnie. And as a result, it got so bad that the nursing home staff actually asked me to leave. And I went home another 400 miles. And just for any of you that are wondering, it does no good to show your mother who has dementia your driver's license to show it really is you. And it was my action that escalated the agitation, if not having caused the agitation. And so what I learned is that as care partners, we have such an important role if we understand how to respond in de-escalating agitation and in some cases preventing it altogether. What was really the issue there? I felt terrible that I didn't matter anymore. And that's really what led to my depression. But with these comments, I don't want to imply that there's one size fits all, that everybody should do things the same way. Instead, what we all have to figure out as care partners, and this includes the multidisciplinary team, is to figure out what's important to the person, what matters most to them, and lean into that. I'll give you an example of that. When that happened in the nursing home, it was a wonderful direct care worker who really got to know my mother, in part through talking to me and the rest of our family. And the biggest issue at that time that was causing agitation for my mother was actually bathing. And so what this direct care worker thought would work, and the rest of the staff said, just try it, is that she knew my mother always wanted to lose that last 5 pounds. And so what she said to her, she'd walk in the room and she'd say, "Miriam, oh my gosh, it looks like you lost some weight. Let's go weigh you." And of course, my mother went right over to the scale in the shower room, took everything off and even helped. And as a result, her clothes were off and it was easy to get her into the shower then. And do you know, she never, ever had a problem with showering again. And so when we talk about care partners, we have to realize that in care communities, if we could always flatten the hierarchy and make sure that decision-making is being made by the people who know the person best, then agitation can be reduced or minimized as it was in my mother's situation. So to sum up, even though my mother was at the time on the only drug that was available then, it was not making much of a difference. And so what we could have done would have had an enormous impact. And I believe what care partners do now still has a very important impact. So what did I learn? What I learned is that if we all work together, we can prevent or reduce or de-escalate agitation and in general make life better, not just for the person who is living with dementia, but for the whole family. And that's where I use the term the people who are impacted by dementia. And so to close, for those of you who are members of the clinical care team, my plea is that you include us, the care partners, as active members of the team. And I want to give you a quick example of something that happened fairly recently when I was involved with a care team. And that is, I had a sheriff who actually came to me and said, "We have an issue. There is a woman who is so agitated. She is pacing. She calls us and explains, there is someone in my house." And I said to the sheriff, "I can help you figure out what might be going on." And so we got a positive invitation to the home by the family, of course. And I had an idea already what was going on. And it turns out that she was always calling the 911 at about the same time each day. And what was happening was she was seeing shadows because of the lighting in her room. And it was her own shadow that she was seeing. So of course she was getting agitated. Of course she thought there was someone in the room. And you know what we did? We bought soft light bulbs instead of the really bright light bulbs And do you know, she never called again. And so it was this kind of interaction of all members of the care team, including the informal care partners, that actually changed her life, changed her family's life, and taught the multidisciplinary care team quite a bit. And so my final message is that by changing the narrative, by helping care partners and those who are living with dementia understand that there's so much in our toolbox now. There are pharmaceutical interventions, there are non-pharmaceutical interventions, which are the person-centered care approaches that allow us to do so much together. And if we can focus on strength-based, person-centered care and caring, we can do so much to reduce agitation and to make a better life for everyone who is impacted by dementia. And so right now, what I'd like to do is turn the program over to my colleague, Dr. Ishmael, who's going to explain to all of us what is known about the burden of agitation in Alzheimer's dementia. Thank you so much.
Hello, I'm Zainur Ismail. I'm a professor of psychiatry, neurology, epidemiology, and pathology at the University of Calgary in Canada. I'm going to discuss the burden of agitation associated with Alzheimer's disease. As you just heard from Bonnie, care partners play an essential role in identifying agitation and recognizing its triggers. Despite these triggers, however, care partners should not blame themselves for the agitation, whether it be verbal aggression, physical aggression, or excessive motor activity, as there's an underlying neurobiology to agitation. Care partners bear the emotional, physical, and often financial repercussions of caring for someone with AD. There's also stigma associated with the behaviors that comprise agitation. This can lead to delayed recognition and more severe consequences of untreated agitation, which can cause mental strain on care partners and families. Now, Bonnie's not alone. The impact of agitation in Alzheimer's disease on care partners, patients, and healthcare systems is profound. With respect to the care partners, there's higher stress, greater rates of depression. They spend more hours per week on care than non-agitated persons with AD. There's a greater need to hire professional caregivers. There's lower employment income and greater stress and burden overall. On the patients, when you take people with agitation compared to those without, the agitation represents a worse phenotype, as evidenced by greater functional impairments, poorer quality of life, higher rates of hospitalization and institutionalization, excess morbidity and mortality, more rapid disease progression, and on autopsy, a greater plaque and tangle burden in those who have agitation versus those who not. Again, emphasizing the neurobiology of this. On healthcare systems and providers, the results are also substantial. There are more consultations to physicians, increased likelihood of hospitalization or institutionalization, longer lengths of stay when people are hospitalized. Some data for the UK compared people with Alzheimer's disease with and without agitation and found that the total direct healthcare costs, including also accommodation and external supports, were £29,000 for those without agitation, and at the more severe end, £57,000 for agitation. So you can see there's a great impact. These Japanese data also tell us about the importance of behavioral symptoms on agitation. These were geriatric psychiatry inpatients in Japan, and a principal component analysis was done to look at contributors and predictors of hospitalization. And amongst the first factor on the principal component analysis were all three IPA agitation domains, being verbal aggression as measured by irritability and lability, physical aggression as measured by agitation aggression, and excessive motor activity as measured by aberrant motor behavior. Again, indicating that these are very important and impactful behaviors. When it comes to the severity and scope, agitation is associated with other more comorbid behavioral symptoms, more apathy, more depression. There is an increase in agitation severity over time, and that prevalence can be up to 88% of people with Alzheimer's disease, generally in the 50 to 60 range, in addition to all the care required by partners and systems. Here we can see global differences in prevalence of agitation. Suffice it to say that it is prevalent everywhere, but there are cultural variations as well. In some countries and cultures, access to institutional care is easier or more culturally acceptable, and in some it is completely unacceptable. And the notion is unequivocal that people should stay at home as long as possible. Managing agitation increases the likelihood that they will stay at home. So looking at the big picture, the prevalence of dementia was an estimated 57.4 million people worldwide in 2019, some 60 to 70% with AD. In 2050, it's estimated that there will be almost 153 million people living with dementia worldwide. Although with the aging population, the dementia cases are expected to rise in every region, the largest projected increases are expected in East Asia, North Africa, and the Middle East. We need to be prepared. Bearing in mind the high prevalence of agitation in those with AD, as well as the effect on the patient, the care partner, and the healthcare system, we need to be able to detect agitation and reduce its impact. I'll hand this back to Dr. Ali Reza Atri to discuss detection and diagnosis of agitation.
Hello again, I'm Ali Reza Atri. Now that you've heard about the burden of agitation, I'm going to discuss diagnosing agitation associated with AD. So one of the main things that I always discuss with patients and families early on, and also with clinician colleagues, is, the first step of any process like this is to have a timely and accurate detection and diagnosis. But even before that, it has to be on your radar. So earlier we talked about the formal definition of agitation in dementia by the IPA. As you recall, it has to be in a patient that meets the criteria for a cognitive impairment or dementia syndrome, such as Alzheimer's disease. It also has to have a behavior, at least one, that is associated with distress, emotional distress, that is persistent and frequent enough, that has occurred for at least 2 weeks. There's a change in behavior, and it's severe enough to really impact interactions with the patient, them receiving care, ADLs, and maybe their social structure. So how can we early on get this on patients' and families' radar? So I like to always say, with a question that sets up the framework as, has there been a change in interactions or behavior that is completely new and maybe bothersome to you or to the patient? And patients and family members may come in and they may describe things like, well, he's more easily upset, or he gets angry, or restless, or he's doing this on purpose. There is something, but they're really being ornery. And I ask questions in the different domains. So, for example, I say, well, has there been anything such as pacing, rocking, repetitive movements, sometimes vocalizations, and patients may not recognize that this is a potential symptom of agitation. Verbal aggression is something that they, if it's a change in behavior, is oftentimes described, whether it's yelling or losing their temper, shouting, screaming even, using profanity. And then, of course, physical aggression is something that we're all concerned about because of safety of the individual. It could be anything from kicking, throwing things, slamming doors. But one has to recognize these early so that we could investigate. So the IPA suggests a kind of a mnemonic that goes along with IPA. And the I is for investigate, the P is for plan, and the A is for act. So we want to investigate really these agitation episodes, think about what may be triggering them, what may be associated with them. Really, what is the impact? That's really important. What is the impact on the patients and families in basically their emotional health, their ability to receive care, potentially, their medications, or treating their common comorbidities. So the IPAs investigate suggests, again, understand the behavior that's occurring. Does it meet the criteria of agitation? And if it does, think about, again, both the magnitude, the nature, and the timing of it. Is it happening, for example, timing? Is it in the morning? Is it in the evening? Is it after lunch? Is it always when you are the patient's being approached, for example, for care, for grooming? Is it happening when there are a lot of people around? And this could be the precipitating factor. What is the frequency of it? How long does it last? And how diffusible is it? How is the communication being managed? And really one of the main things is there potential for safety harm at that moment? The foundation is always to do this investigation and then characterize it. So you can do this holistically, with a series of questions, or we have rating scales. Now, some of our rating scales are used in clinical trials, and they require some expertise and time to administer. But there are things like, for example, the Neuropsychiatric Inventory, MPI questionnaire that can be used. It has an agitation subscale, for example. Now, I'll give you some examples of the 12-item MPI, agitation aggression. But basically, you want to ask the care partner, does your loved one have or patient have periods where they refuse to cooperate, or they won't let people help them, or they're hard to handle, they're resistive? And there are questions such as, do they get upset when you're trying to care for them? Do they seem stubborn to you, uncooperative, hard to handle? Do they curse or shout? Do they kick, throw things, hit people, bite? Or in other ways act aggressive or seem agitated to you. And you can think about these in a qualitative way, but oftentimes what we'd like to do is to think about how frequent these things are, how severe are they, and then what distress is it causing both the patient and also the care partners in this behavior. So again, as the first step of the process, it's understanding it, having it on your radar, and then being able to make sure that this fits a agitation syndrome category, and then measuring it with tools. And of course, this is all foundational because it's going to really help us think about the major step, which is non-pharmacological approaches to agitation in AD dementia that we always have to do first, and I'll talk about in the next section. Hello again, I'm Alireza Atri. Once we've identified agitation in Alzheimer's dementia, our first step is to use non-pharmacological approaches. And this is going to be the topic for this thing. As we went through, the IPA approach to agitation can be classified with a mnemonic IPA, the I being for investigate, the P for plan, and A to act. And it is foundational that we use this approach. Again, once we've classified and thought about agitation AD, to investigate not only if does this meet the criteria for agitation, but thinking about the timing, the duration, severity, impact, nature, associated symptoms, and the potential for harm to others. And if there's absolute immediate crisis, then that's a different stream that requires urgent evaluation. And sometimes pharmacological approaches need to be employed. But beyond that, really the foundation comes to thinking about the non-pharmacological behavioral approaches. So once that is investigated, we need to think about a intervention, removing the triggers, mitigating it, and use a shared decision-making approach, patient-centered as much as possible, um, to implement it, and then to act. That's both implementation and also to have a pathway to evaluate. And again, you'll hear from Professor Langto about pharmacological therapies in the next segment, and from Professor Grossberg. What may be some of the approaches that are addressed at agitation, for example, at home, patient factors, environmental factors, care partner factors? So if one were to think about, aspects that I like to break down, could this be a condition that is medical, neurological, psychiatric? So what are some of those things that may be common but missed? So is there sleep disturbance? Does the patient go to bed and they're actually up most of the night and their sleep-wake reversal, and that's not known? Is there pain that they're not expressing? Is there sensory impairment that's causing confusion? Is there a language impairment that's causing confusion? Are there psychiatric or other emotional issues, including depression and anxiety, that the patient may be experiencing? Could they be really, really bored and lack stimulation? Now, the other part that's also medical is metabolic. Very, very common for patients to actually be dehydrated, to have electrolyte abnormalities. If they have other conditions, as they become agitated, those may not be actually addressed well. They may be resistant to drinking or eating or taking their medications. So are there medical comorbidities, hypoglycemia, hypertension, other things like that? And then when we think about the other category of toxicology and medications, are they being overdosed or underdosed? Could it be that someone recognized some other part of the syndrome, and now suddenly they have anticholinergic medications that have been added on? They're making them more confused. Is there a benzo involved, for example? And could they be, coming out more confused or withdrawing from things? Alcohol, if they drank too much and they don't remember. So think about the beers category, and also think about, are there subclinical infections that are manifesting in agitation first? In women, for example, UTIs. Could there be other systemic infections going on, bronchitis and pneumonia? Could there be COPD? Could they have low oxygen that's causing now a encephalopathy or a delirium? Bowel and bladder issues can be common. Are they constipated? Is there urinary retention? Are they feeling dirty or unwashed? They had issues, for example, with incontinence. And other environmental triggers, too hot, too cold, too much stimulation, changing care partners or communication styles. So one thing I would say is that no one comes out of the room knowing how to be a care partner. I cared for my dad at home, and before that, for my aunt. And people have different aptitudes for it, but you actually have to learn this stuff. It's not easy. So the idea of having patient-centered care is really, really important. And thinking about what matters to patients themselves, but also creating an environment that's calm, removing the stressors, a place that they feel safe and secure, and having rituals, and also not giving them additional things that may overstimulate them. For example, caffeine too much. What other triggers? As I mentioned, noise or glare can be something. For example, in Bonnie's talk, we heard about a woman with AD and agitation who reported, intruders. And this was really, really concerning, caused fear and agitation. And the fix was changing the lighting and eliminating the shadows. And it was addressed in that way. Having the TV on at the background all the time, or actually having them sit in front of the TV and watching the news, for example, that can be really polarizing and upsetting to people, or programs that may be upsetting to them with violence or other things. Having too many people in the room. So you have to have the just right activity for them. Looking at personal comfort, as I mentioned, hunger, thirst, bladder, temperature, having routines that keep people on task, including, with bathing and dressing. And one part that I really stress is some aspect of physical activity and exercise. And they may not be able to initiate that, but going for walks if possible, going to the garden, putting music on, reminiscing together. Um, but at the same time, allowing the patient to have as much control and to express themselves to you. To listen to to frustrations, to provide reassurance and be really calm is really, really important. Patients obviously will pick up on cues, especially redirecting into people, involving them in activities they may like. And then also, I always say to the care partner, this is really, really hard. And sort of checking your own sort of temperature and grade in the way you communicate is really, really important. But it is important, unless safety, absolute safety is involved right away, not to try to correct them all the time, not to try to confront them all the time, not to try to convince them of something. Maybe it's just better to just redirect. So there are other non-pharmacological approaches that can be done, for example, both in the home and in the community, but also in nursing home settings. And there's some science behind that and some evidence behind that. Oftentimes, it requires a bit more structure, a bit more training. There are things like, for example, reminiscence therapy, music therapy, structured social interactions. There's bright light therapy, aromatherapy, and even therapeutic touch. And I think group level activities, if it's in the right setting and it allows people to become adjusted, can be really, really important. And really trying to make sure that the environment and the activity is just right and allowing them time to adjust to those things. So in conclusion, the considerations that we have when we aim to manage agitation really is, again, investigate it, think about the behavioral and neuropsychiatric syndromes and symptoms, including agitation, have these conversations with caregivers as part of their education early on. And when they occur, and you're able to broach the subject again, it hopefully at every visit and can detect it and diagnose it accurately, then to start doing the root cause analysis, to put in an intervention, to act, to monitor that intervention, and then modify your plan as things go along. And this will really make a difference. And finally, having consistency and compassion and good communication and simple routines, and having this as a foundation for the approach to the syndrome of agitation and aggression, and that we oftentimes in Alzheimer's disease and dementia. And not to confound, calmness and sedation, and not to be in a crisis mode where we have to reach for pharmacological treatments, which sometimes we have to, and that you'll hear more about from Professor Lanto and from Professor Grossberg about our new options in care.
Hello, I'm Krista Langtel. I'm going to talk about pharmacologic approaches to agitation associated with Alzheimer's disease. I should mention now that most pharmacologic approaches are used off-label. To provide a context for pharmacologic approaches, I'll use the recent IPA agitation treatment algorithm. In that algorithm, psychosocial care is considered first and continued throughout to decrease or avoid future agitation. There's also consideration of concomitant medications. It's recommended that you curtail the use of medications that may cause agitation and optimize use of cholinesterase inhibitors in persons with Alzheimer's disease. If there's an adequate response or the potential for harm, that's when pharmacologic care is recommended. Pharmacologic care is personalized. Major features that may guide initial choice include whether the agitation is circadian or nocturnal, when sedating psychotropics may be helpful, whether agitation is mild to moderate or has mood changes, whether agitation is moderate or severe with no danger to self or others, or whether agitation is severe with threat of harm. Pharmacologic approaches that have been evaluated for agitation in clinical trials are mainly off-label and include psychotropic medications from a wide variety of therapeutic groups. Those include symptomatic treatments for Alzheimer's disease, as well as antipsychotics, antidepressants, alpha-1 antagonists, analgesics, and cannabinoids. First, I'll review the evidence for symptomatic treatments for Alzheimer's disease dementia. Then, I'll highlight some of these groups where there's newer evidence. Cholinesterase inhibitors are approved for mild to moderate dementia. They have a modest advantage over placebo for the behavioral and psychological symptoms of dementia, including agitation, and there's some evidence from withdrawal trials of their efficacy. However, evidence also suggests that they may not be useful for acute agitation. Memantine is a NMDA receptor antagonist that's approved for moderate to severe dementia. There's some evidence of benefit for mild to moderate irritability, agitation, or aggression. There's no randomized controlled trial evidence of efficacy, but a pooled analysis suggests that there's decreased emergence of agitation with memantine. For mild to moderate agitation associated with Alzheimer's disease, there is evidence supporting the serotonin reuptake inhibitor citalopram. The serotonergic system has been linked to agitation in Alzheimer's disease. The CITAD trial evaluated 186 patients with probable Alzheimer's disease and clinically significant agitation. In that trial, 40% of those on citalopram showed moderate or marked improvement on the modified clinical global impression of change compared to 26% in the placebo group. Adverse events included worsening cognition as well as QT interval prolongation. This prolongation was somewhat expected given that some participants were dosed at up to 30 milligrams per day, above the now recognized cap of 20. Escitalopram is the S enantiomer of the racemic citalopram. Escitalopram has been proposed to have the clinical effects, but not the cardiac effects of the racemic mixture. The ESCITAD trial is ongoing. In that trial, patients with Alzheimer's disease and agitation with insufficient response to structured psychosocial interventions receive either 50 milligrams per day of escitalopram or placebo with continuation of the psychosocial intervention. For moderate to severe agitation in Alzheimer's disease, judicious use of antipsychotics has been recommended, and this therapeutic group is commonly prescribed for agitation. Risperidone is one example of an atypical antipsychotic that has been approved in some countries for the treatment of aggression. Modest but significant improvement has been shown based on randomized controlled trials. Side effects include extrapyramidal symptoms, sedation, gait disturbances and falls, and risk of delirium, and a possible increased risk of cerebrovascular events. Like all antipsychotics in general, there's a black box warning due to increased mortality in dementia. We'll hear more about antipsychotics as a treatment for agitation from Dr. Grossberg in the next segment. Prazosin is a centrally acting alpha-1 antagonist. There's some evidence of increased sensitivity to norepinephrine at the alpha-1 adrenal receptor in persons with Alzheimer's disease and agitation. One small published randomized controlled trial showed that prazosin appears to improve overall behavioral symptoms in individuals with agitation and aggression. Based on the limited evidence, prazosin may be useful as a second-line treatment for the management of agitation. Dextromethorphan has also been evaluated for agitation. It acts as a sigma-1 agonist, an NMDA receptor antagonist, an alpha-3 beta-4 and alpha-6 nicotinic cholinergic antagonist, and a serotonin and norepinephrine reuptake inhibitor. 3 trials have evaluated dextromethorphan in combination with quinidine. Quinidine is put in this combination to slow the metabolism of dextromethorphan. Unfortunately, the phase 3 Triad 2 trial and the most recent phase 3 worldwide Triad trial both did not meet their primary efficacy endpoints. Dextromethorphan has also been combined with bupropion, again to decrease its metabolism through cytochrome P452D6. Bupropion is also active and acts as a dopamine and norepinephrine dual reuptake inhibitor. There are 3 randomized controlled trials that have evaluated this combination, dextromethorphan plus bupropion, for agitation in Alzheimer's disease. Advance 1 was the largest, with 366 patients, and the combination showed a reduction in agitation and a greater proportion of patients with a clinically significant decrease in agitation. Advance 1 was preceded by Accord. In the open label phase of Accord, in 178 patients on the combination, there was decreased agitation, improved quality of life, and improvements in care partner distress and burden. Responders from the Accord open label phase were then entered into a randomized discontinuation study. The active medication was associated with a delay in time to relapse, a decreased proportion of relapse, and similar adverse events were found between the two groups. This medication shows promise, and the Advance 2 study is ongoing and will help determine its place in therapy. Nabilone is a synthetic THC analog that's a partial agonist of the cannabinoid receptors. Stimulation of cannabinoid receptor 1 and cannabinoid receptor 2, or CB1 and CB2, can be expected to be calming, increase appetite, and decrease pain, and that could be important in people with agitation. My group evaluated Nabilone, 1 to 2 milligrams per day, in a phase 2 study in participants with moderate to severe agitation of Alzheimer's disease and moderate to severe cognitive impairment. Patients received Nabilone and placebo in a randomized crossover trial. Treatment differences favored Nabilone for agitation, plus overall behavioral and psychological symptoms of dementia, care partner distress, and cognition. As expected, there was more sedation in the Nabilone phase, but it was well tolerated overall. Like other second-line medications, Nabilone has limited evidence and at this point might be considered for agitation when other medication classes have been ineffective or not well tolerated. There are numerous ongoing trials with cannabinoids, including dronabinol, which is synthetic THC, medical cannabis, and our larger Nabilone trial. Together, those studies will provide needed evidence on this therapeutic class. Other molecules being evaluated include dexmedetomidine, which is given as an orally dissolving thin film. Dexmedetomidine is a selective alpha-2A receptor agonist. It had positive results for the treatment of acute agitation associated with dementia. Meserpidine is a 5-HT6 receptor antagonist. A post-hoc analysis of a phase 2 study in persons with moderate Alzheimer's disease serendipitously found that treatment significantly decreased agitation. To further evaluate this, a 12-week phase 3 trial is ongoing. In summary, there are few approved pharmacologic treatments for agitation associated with Alzheimer's disease, and one new approval that we'll hear about. For current practice, it's based on assessing the severity of agitation and the avoidance of side effects, so it's basically trial and error. Most current medications are used off-label and may not be based on a substantial body of randomized controlled trial evidence. They may be associated with serious side effects, and patients may require close monitoring. In addition, they have small to at best medium effect sizes. There remains a large area of unmet need in this area. We need treatments that are both efficacious and safe, and research continues in this area. George Grossberg is now going to tell us more about antipsychotic therapies, particularly one that is approved for agitation in Alzheimer's dementia in some countries.
Hello, I'm Dr. George Grossberg. I'm going to be talking about new therapies for agitation associated with Alzheimer's disease or Alzheimer's dementia. In this segment, I will focus primarily on data for the atypical antipsychotic brexpiprazole, which has recently been approved in some countries, including in my country, the United States, for agitation associated with dementia due to Alzheimer's disease. As Dr. Langto has mentioned, we do have a history of using other antipsychotic medications in this setting. Some off-label, most of them off-label, and one which is risperidone, which is approved in Canada and in some other countries. As was also mentioned, in the IPA agitation algorithm, we do talk about using antipsychotic medications if, in fact, non-pharmacologic approaches have either failed or where we have very severe agitation that requires medication that's going to promptly control the behavior because of potential danger to self or to others. We know that in looking at other antipsychotic medications, particularly the atypicals like risperidone, quetiapine, which is probably most commonly used, olanzapine, aripiprazole, that they do reduce agitation to some degree, not significantly, but the major concern is really side effects, whether it's sedation, whether we're looking at Parkinsonian or extrapyramidal side effects. And of course, we have the box warning about increased prevalence or incidence of even mortality with the atypical antipsychotics. So building on data with the atypical antipsychotics, large studies, in particular phase 3 studies, were undertaken to look at brexpiprazole in agitation associated with dementia and Alzheimer's disease. And we have, in fact, the 3 large trials, but we're going to focus on the third study because that's the one that utilized the effective dose of brexpiprazole uniformly, which is considered to be 2 milligrams a day of brexpiprazole. There was also a 3 milligram dose, which did not do better than the 2 milligram dose as far as efficacy. Now, interestingly, too, the third trial was a little bit different design because we learned from the first 2 phase 3 studies. And one of the things that we learned was that we really need to have kind of pretty serious agitated behavior. So in the third study, we had patients that were more seriously agitated and even having more overtly aggressive behaviors as defined by the Cohn-Mansfield agitation inventory. These were generally individuals that had mini-mental scores between 5 and 22, and they were divided into 2 groups, 12-week study. The first group were individuals who were randomized to either 2 or 3 milligrams a day, built up gradually, of brexpiprazole. And of course, the second group was the placebo group, and all of them were treated for 12 weeks. When we look at the results, and these are 2 areas that are very, very important, obviously the agitation inventory, the Cohn-Mansfield agitation inventory, showed highly statistically significant benefits of brexpiprazole versus placebo. We begin to see separation as far as agitation at week 4, and it continues at week 6, 8, all the way through week 12 versus placebo. But the other important data is the CGI, the Clinician's Global Impression of Severity score. And here too, we find statistically significant benefits of drug versus placebo. And the reason the CGI is so important is that that's the one that shows you the visible clinical benefits. We also know that if we look at the Cohn-Mansfield agitation inventory, that really patients did better in a whole variety of different areas, whether it was aggressive behaviors, whether it was physically non-aggressive behaviors like pacing and so on, or even kind of verbally agitated behaviors. If you look at drug versus placebo, there were statistically significant benefits for both. And then similarly, the neuropsychiatric inventory, the total score was again highly statistically significant for drug versus placebo. Now, getting back to this notion of clinical meaningfulness, I mentioned earlier that the measure that the Food and Drug in our country requires to show clinical benefit is called the Clinician's Global Improvement Score, where we grade patients about, are they better? Are they a lot better? Are they about the same? Are they worse? Can the clinician notice, not knowing who's on drug and who's on placebo, if in fact that this is the group that's benefiting? And when we break the blind, we find that indeed those are the patients who happen to be on drug versus placebo. So the clinical global impression response rate is very, very important, and in fact was statistically significantly higher with brexpiprazole versus placebo. If we look at the Cohn-Mansfield, you can also look at on the agitation inventory what percentage improvement on the Cohn-Mansfield patients had on drug, again, generally 2 milligrams of brexpiprazole a day versus placebo. And you see that at every level, 20% improvement, 30%, 40% improvement, there were statistically significant benefits of being on drug versus being on placebo. But I think, as you know, the regulatory authorities are not going to approve any medication unless it's relatively well tolerated. So here we look at the safety data. One of the things that's very important to keep in mind with the safety data is that there was only one side effect of brexpiprazole that had an incidence of 5% or greater versus placebo. And that happened to be headache, which also was equally as high with the placebo group. There was some somnolence, occasional dizziness, but what we didn't see, which is very, very important for an atypical antipsychotic, is there was no evidence of falls or fractures, no evidence of extrapyramidal or Parkinsonian side effects, no evidence of sedation. There was no evidence of severe cardiovascular or cerebrovascular side effects. So, again, the profile was a relatively benign one for an atypical antipsychotic. But because it is an atypical antipsychotic, we do have the box warning of increased mortality in older patients with dementia-related psychosis, not agitation, but psychosis treated with any antipsychotic, including brexpiprazole. In these studies, the 3 large randomized placebo-controlled trials, there were 7 patients who died in the 3 studies. 6 of them were exposed to brexpiprazole and 1 on placebo. However, when we looked at the cause of death in all of these patients, there were none that were related to brexpiprazole. The other thing that's in the package labeling in our country, which is very important to keep in mind, is that this is not a PRN drug. This is not the emergency department, the acute drug for out of control patients. As we showed in the data, you begin to see separation from placebo at week 4, between week 4 and 6, and you begin to see more and more separation thereafter. So it's a drug for the long haul, not an acute drug. We also want to keep in mind, as you heard from my colleagues in the previous segments, that there are a variety of different approaches to managing patients with agitation and Alzheimer's dementia, and a number of medications are in the pipeline. They're being studied: escitalopram, deuterated dextromethorphan, quinidine, dextromethorphan, bupropion, nabilone, prazosin, dexmedetomidine, a very interesting compound, and even tetrahydrocannabinol and cannabidiol are being looked at and studied for agitation and Alzheimer's dementia. So let's talk about some take-home messages. So we've heard in this program that agitation associated with Alzheimer's disease dementia is in fact quite common worldwide. And we know its severity increases as the disease progresses. We know that it poses a significant burden, physical, financial, emotional, on both the patient as well as the care partners, and is a leading cause of earlier placement in long-term care environments, nursing homes, for example. We now have a definition of agitation in the cognitive disorders from the IPA, the International Psychogeriatric Association, which can be employed for research purposes and also identifying clinically meaningful agitation in the clinic. We know it's very important for all of us as clinicians to, at every visit, ask about behavioral problems, changes in behavior, agitated kind of behaviors. And of course, always inquire from the care partner. Sometimes care partners are reluctant to share this information because they don't think agitation is part of Alzheimer's disease, or there may be a stigma that may keep families from reporting behavioral symptoms like agitation. And of course, it may be useful to use an instrument to quantify agitation and then to get back to that instrument later after we've proposed an intervention. So now we have, the IPA agitation definition, also an algorithm for differential diagnosis and treatment, which always calls for starting with non-pharmacologic therapies, always includes making, for example, sure that we're communicating with the care partner, we're appropriately educating them, that we work together as a team. We have a number of pharmacologic approaches. Almost all of them are being used off-label, which don't just include the antipsychotics, but also include anticonvulsants, antidepressants, and so on, all of them pretty much being used off-label, except for the recent approval of brexpiprazole for use in agitation in Alzheimer's disease dementia. As we mentioned, there are a variety of new therapies in the pipeline. And of course, we always want to keep in mind that our really number one priority is really to improve the quality of life of patients, of care partners, whether it's family or those working in the long-term care environment, as best as we can. Thank you all for participating in this activity. Please continue to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.